Hi, good evening, all. I'm John Compson. I work at King's College Hospital in London. I've been here for about 25 years now, but I've been always interested in anatomy. In fact, I was as a child, I was a great fossil catcher and paleontologist, and I did a degree in anatomy, which involved dissertations on both lizard in evolution and hominid um, evolution. I almost did an MA in physical anthropology, collecting hominids in the Rift Valley, which would have been, I think, maybe a bit more interesting than working at King's. But hopefully that this interest in anatomy has gone on to my surgery. Um, the my feeling is that there's too much science in the craft of orthopedics or hand surgery, and this is mainly based on the fact that all we can do in surgery is change anatomy. So it's more important to be able to understand anatomy and be able to visualize it and see things in 3 dimensions, which gives you a much better idea of why you should be doing things. And also, a good knowledge of anatomy helps you because a lot of the cases we do is quite bespoke surgery. Um, the three main things I was going to talk about is the fracture of the scaphoid, but the anatomy behind it, because there's quite a bit to that, which has actually gone through from an early stage when I was an SHO, and it's been an interest of mine for many years. Also, I've been trying to start early mobilization of transcarpal injuries to stop stiffness, and because of this, I've been looking at soft tissue repairs as well as bony repairs to see if we can get things going quicker and reduce the amount of stiffness. And the last one is about the ligaments of basically the CMC joint of the thumb, because that's a particular interest in mine, in particular to try and develop the new mouse or better mousetrap in treating um, CMC joints which need to be LRTI'd after a trapeziectomy. So to start with is the scaphoid. Um, as I say, I do a tertiary referral practice, and one learns from it. But well, in fact, one learns best from other people's mistakes. This has got nothing to do with picture of Carlos next to us here, because he wasn't the type of person, when I was doing these early, would as orthopedic surgeon, would never wear um, uh, of glasses like that. But I started to be interested in the scaphoid when I saw a very good surgeon trying to fix a trapezium to a distal pole of the scaphoid. He realized his mistake after I told him, and he then fixed it. But it also worried me that we weren't reducing these fracture, or in fact non-unions, because the premise behind any fixation of any fracture or non-union is to restore normal anatomy, to fix it strongly and to get it going quickly, and we weren't. And in fact, the pictures of these AP obliques, the central picture shows a normal scaphoid, and this has been well reduced and a good position with the screw in. But this is the commonest position after fixation of scaphoids, with a very collapsed scaphoid with a lot of um, bone dorsally. Um, Interestingly, we also found that the screw position was um, poor, and this was in the case when we were doing these with Herbert screws, which was using a clamp. And in fact, at least 5 of these cases, the screws were in the wrong bone. I had one which went all the way from the um, distal polar scaphoid through the proximal and right across the lunate. Um, There's quite a few coming out of the sides, and certain approaches made certain penetration of the surfaces more likely because of the shape of the scaphoid. Interesting, the Swift trial, which has just come out recently, has shown that even with cannulated screws where you've got K wires, it's still difficult to put a wire down even a normal shape of scaphoid when at least half of these showed screw protrusion at the end. We need to be able to get better ways of fixing, so we can be more consistent with our screws position. But for my first study, I decided we ought to have a look at why it's so difficult to fix a scaphoid and reduce it. And this is mainly because it's a very odd shape. It's curved into planes. The bones are overlapped by others, so it makes interpretation with X-rays difficult. In fact, X-rays are better than cuts of CT scans, because at least with scaphoids you can actually look through and see some degree of three dimensions in it, but it's quite difficult. This is made even worse when the bone view of the bone, and very difficult to really appreciate how it's collapsed and how we can restore it to its normal shape. The same thing occurs because all the classifications are done on X-ray views. Then it is difficult actually to see what's going on, and there's actually no good classification at all, which makes the science of scaphoid fractures quite difficult. The other thing, it's only really visualized, even with open approaches, a small part of scaphoid at a time, so you have to visualize what goes on beyond that. And this really comes to the analogy of the Crystal Palace iguanodon.
Many years ago, in about 1824, there was a guy called Gideon Mantell who was in Sussex and discovered what he was later called Mantell's horn, which was a part of an iguanodon. It was probably found by his wife, but that was very typical of fossil collectors in those days, that the man got all the glory. But because he found this horn, and it was thought this was like an iguana, these big models were made at the Crystal Palace for the Great Exhibition of 1854. These are absolutely huge things, but as you can see, they look like iguanas, and on the tip of it there is a horn. In fact, they've later found that when they found a whole load of dinosaurs fossils in Bernissant in Belgium, that the horn was actually a spur on the front foot. So this was the next design of Iguanodon, with it walking on four things. That wasn't enough though, because they didn't really think about the anatomy of the soft tissue. But by that time, they actually now realize that the Iguanodon probably walked upright. But the same thing goes when you're looking at a scaphoid like this. How the hell do you know if that's reduced or not? Because you get so little a view of it. You have to actually transpose what is going on behind it. And this skill is probably the mainstay of good treatment. When we started, we really had to go right back to scratch when we were looking at the scaphoid, and that started by looking at radiological markers, because in fact the only anatomical bit on the scaphoid at that stage was the tubercle, and we described various parts of the scaphoid which you could describe on X-rays. But funny enough, it did go into nomina anatomica for about 2 years, but then the anatomists had an argument about what to call the nomina anatomica, and eventually it changed, and my descriptions of scaphoid got lost, so that I need to go back to that. But it was being an anatomist, I was very pleased to get actual names in nomina anatomica. At the same time, we were doing macro radiographs, and we found, looking at the trabecular structure, which I'll talk to you about, but it soon became clear that the shape and variation was actually quite extreme, and this made a great difference to how we visualized the scaphoid. And also there were some very specific things about the variation in shape which will affect how well it can be fixed or not. We then came up with the best radiological views, and then on to radiological screw position. From the alignment and movement, which is obviously important for the radiology, we also started to develop some ideas about how the scaphoid fractured, and why it only it rarely was accompanied by ligamentous injuries. A quick bit about the blood supply. I was working with people who were the sort of doyens of vascularity of bone, and they didn't believe anything about the blood supply, and thought that it was just an excuse for surgeons doing bad practice. And they thought that all bone would get a good blood supply if it was fractured. also importantly was the fact that the scaphoid is a bone of two ends. One end is very stable and stuck in one position. The other end is very mobile. And like the Jones fracture in the fifth metatarsal, is you get long unions because of movement around the rigid proximal end. Following that, we went to fracture alignment because the fracture and its alignment in the anatomy was very important, particularly about the natural history of how it collapsed, lost bone, and so and so. So if we, but that was all done with before the time of really good CTs, and we couldn't get any 3D CTs like that. And I think that the 3D CT has actually been the greatest advance in orthopedic surgery recently. It has given us such an unbelievably good view of the bone in 3D. But what it doesn't do is to then be able to conceptualize the soft tissue onto it, and that's what you have to do with by dissection and looking at pictures and trying to work that out as well. These are scaphoids. Donald Salmon, eat your heart out if you're there. Some of my pictures, but it basically showed this is obviously a Caucasian scaphoid. It's one which I used to carry around for years, but because it shows all the things like the dorsal, this is the back of the scaphoid, dorsal ridge, the groove where in fact the main ligaments lie in the back of there. What's also worth noticing is it's a very large STT joint. This tubercle isn't actually particularly big, and we name these couple of points: the lateral apex of the ridge and the dorsal apex of the ridge, because this is a point you can often see on the scaphoid X-rays. And this is looking at the lateral view. Again, this middle section where the soft tissue attachments, which is quite wide and noticeably is full of holes for vascular supply. This is the proximal pole, again, the sloping large STT joint. On this view from the inside, you can see how big the facet for the capitate is, and I'll talk later about the size of the actual width of the scapholunate joint and its significance. There's also an area in the front of it which I now call the crumple zone, or the compression zone, which is where always the scaphoid gives, and it all buckles in the childhood fractures. The alignment is pretty interesting as well. You can see the curve of the bone, but it also lies at 45 degrees and 45 degrees. But again, you can see how well the 3D CTs show this now. Interestingly, and this is very specific for the radiology, is the tubercle isn't really a lump of bone on a scaphoid. It is actually part of a rotated distal pole. Like this, and this is highly variable, but averages about 40 degrees, but very hard to measure. There's also great variety in the shape of the scaphoid, which we'll talk about a little bit later. We had to describe things like the actual anatomical waist, the true anatomical waist, which is in this area. So when you start talking about waist fractures, you've got to be a bit cautious, because this is the true waist of the bone. It's also almost impossible to define the tubercle, but where we have done is put it between the trapezial and the trapezoid parts of the STT joint. This is an interesting one. The scapholunate width is between 3 and 8 millimeters. In fact, the big scaphoids often had the smallest depth of the scapholunate joint. And you sometimes in some of these, you can see how difficult it may be to put a slam down through this joint, which is well over 3 millimeters across. So you have to be very cautious and know about this can happen when you're doing anything with a scaphoid. These stars are also an interesting thing, which I'll talk about later. These are the attachment point of the scaphocapitate ligament, which is a very important in the ligament for stability of scaphoid. The other thing we soon found out, the shape of the scaphoid actually makes it very difficult in some scaphoids to put a screw down the center of it. In the Caucasian scaphoids we looked at a whole load from Huguenot ones from, in fact, a big Huguenot cemetery in Fleet Street. where they had all the they were all in lead coffins. They'd been there for 400 years, so we all knew they were all Northern European. And in those, there were I think at least 4 where you couldn't get a screw from the tip of the proximal pole to the tubercle, which is where the screws are normally put in from. This was worse actually, or more of a problem in the Guy's collection, which probably a lot of them comes from the Indian subcontinent originally, but they've been there for at least 150 years. But I think in those they tend to be smaller and more like this shape, which is not a Caucasian one. Radiology of the scaphoid anatomy. If you look at there's several views we came up with. The lateral view, the anatomy is, I always teach people that there's 5 curves: radius, proximal pole or proximal surface of the lunate, distal, the proximal pole of the scaphoid, which is the 3rd curve. The 4th curve, which is all congruous, is the distal cup of the lunate, and then the 5th is the capitate. And you can see the scaphoid sitting nicely down here. You can always see the tubercle. So if you join up the tubercle with the 3rd curve, you'll get the scaphoid. And if you carefully, and as this is saying, is look through bones when looking at X-rays, you can see the transverse waist fracture, and that's a true waist fracture. It's bang on the line of the surgical waist. That means that because the scaphoid sits at 45 degrees, your PA view will show it foreshortened at 45 degrees. So it will show, so your waist will be at an angle. To get the waist more in line with the ray of the X-ray, you ulnar deviate, and that will extend it by about 20 or 30 degrees. But to get a true long axis view, you have to tilt the beam towards the elbow. So this is an undeviated view. The scaphoid is longer. It will show some of the oblique fractures a bit better rather than the true waist fractures. And this is the long axis view, which is basically at right angles to the long axis of scaphoid. And that we do it by tilting the beam towards the elbow, but all these specialist views are pretty much to do just that. As I said, the distal end of the scaphoid is oblique and rotated compared with the proximal pole is the PA and lateral. Of the distal pole, it's a 45 degree PA oblique, which is this view here, and the 45 degree AP view, which is the one opposite. This is also called the ball catcher's view, or we'll show the pisiform, because you can see the pisiform here. But this shows the scaphoid very well, and it also shows it collapsing. But as I said before, it doesn't show, you can't measure it very well. And so these are basically though there are 6 views for the scaphoid series, the neutral PA is probably pretty useless. And these are what the proper scaphoid series is. The mechanics of anatomy of the scaphoid is interesting because falling on the outstretched hand doesn't seem to be the most commonest cause of fracturing a scaphoid. In fact, we're trying to write a paper at the moment to show that to fracture your scaphoid, the easiest would be to be an amateur goalkeeper and go into goal asked by your mates and try to save the ball, which is I think the commonest. But you can also fracture scaphoids with handlebars, and that is also very common. And funny enough, a motorcyclist is more chance of breaking a scaphoid if he doesn't come off his bike, because it's the handle grip. And when we were looking at the anatomy of the scaphoid, this became fairly obvious, because if you extend your wrist, the scaphoid doesn't go much beyond 90 in line with the radius. And you can feel it on your own. So if you put your finger on the tubercle and the proximal pole and you extend the wrist, the tubercle remains in front of the line of the radius. And we can see this in this CT scan we did many years ago with a cadaver wrist. And what happens is the trapezium goes over the top. It's not that the scaphoid hinges, and the scaphoid shortens and crumples like cracks a nut, and it cracks it over one of the ligaments which runs across the front of the wrist, normally the radiocapitate ligament. And this is why a scaphoid fracture doesn't normally have any ligament injury with it, because it's a compression injury where you get crunching and collapse at this volar surface, opening at the back. And this gets even worse as over time. And it's one of the why you get opening at the back here with a non-union. And it doesn't come over the back like this and hinge on the back of the radius like that. And if you look at this way as a cause, this is much more likely to cause the fracture patterns and other things, even like in children where you get the torus fracture down at the volar side is compression fracture. These aren't very good for because they're not mine, but these were in fact macro radiographs we did a study, and in fact the crumple zone at the volar surface is actually has a porosity of trabeculae, and you can see why it crunches there. Sorry, blood supply. When we started, the only thing to know about the scaphoid is the proximal pole blood supply was awful. However, there were two people who wrote a book, Murray Brooks and Bill Revel, who both unfortunately are dead now. But they, when I first went to work in St Thomas's looking at scaphoids, told me that the bone always gets a blood supply if it's broken, and not to, and all these studies on it were because of the how you infused the dye rather than the true fact. In fact, these two people later on showed that this scheme where the proximal pole doesn't get a blood supply wasn't quite right, and if you do micro perfusions, you can start seeing vessels coming up into the proximal pole of the scaphoid, and here you can see there's like this little tethering, like almost like the ligament test tube on the other side, and that's where the blood supply goes. If you're going to remember anything about this talk, could you please remember this picture? I think it's absolutely wonderful. I don't think this is the scapholunate joint, and this is the ball of where the head of the capitate sits in, and this is absolutely beautiful. This sigma-shaped scapholunate joint, and it's designed to keep the shape of the socket as the capitate moves through it. This is, and you can see this part of the scaphoid is very similar to this part of the lunate, and this is the tubercle coming down here on the scaphoid. The other thing, which I'm not going to talk much about, is this step on the lunate, because when you grip, the wrist goes into ulnar deviation. It pushes the triquetrum down, and the hamate comes down and locks onto this facet, which then locks this ball and socket joint. But it's but if you can say, if you remember, there's another picture I like to remember, but this was one of the most say inspirational pictures I got. Fortunately, I worked for a sarcoma unit where we did some took pictures of the specimens we got from amputations, unfortunately. Now, as I said, the other important thing about the scaphoid anatomy is that the near end is stable and the far end is mobile. And what holds the near end fixed is its articulations, as I've shown the ball and socket joint up here, but also this squeezes into the scaphoid fossa of the radius, and by doing so, you get very little movement either way, even if there weren't any ligament attachments to it. So the articulations are very important. The distal half, however, has very little contact. The can I get rid of Carlos's picture there? I don't know if you can see here, but this sagittal view here shows the distal half with the STT joint here. You see ligaments down here. Because this joint, the trapezium comes way over the top, the scaphotrapezial ligaments on the front are actually quite mobile, and they aren't very as strong as the proximal ones. But so the whole of this complex at the distal end of the scaphotrapezial STT joint is very mobile, and this is why the scaphoid tends to displace around the area of the sulcus, the waist, whichever way you call it. But it's got to do with stability. The dorsal ligaments of the scaphoid are also very interesting, because the main ligament which runs along the back of the scaphoid is actually attached to the capsule as much as to the bone as well. We've taken out the capsule here, but the capsule has also within it got these large ligaments which run from the radius to the triquetrum and then back again. They are actually not very well defined because these were early pictures I did, but in fact, if you look at this carefully, these bands are actually closer to the midcarpal joint than sitting right over the capitate. And this is the volar. So this is, we're looking at this diagram is also very interesting, because if you look at the scapholunate joint here, there's a circumferential, as I said, the capitate sits right inside the scapholunate joint. Around the circle of it, there's a very fine circumferential ligament, which we see when we scope. The actual main part is a thickening of the scapholunate dorsum and to some degree volar, but also above that in the capsule is also very strong bands, which is almost like somebody's put a very strong tape along the back of the proximal row. The volar side is a bit different, but if you look at this situation, if you put a scope in, you can go in underneath the recess here, but there's all these longitudinal structures lying just above it, and in many ways they are attached to the dorsum, or the most distal part of the dorsal face of the lunate and the scaphoid next to it. And this recess is also very important with the anatomy, whereas the actual main scapholunate part, the scapholunate ligament here, is actually quite weak. The strengthening is in these bands over the top. This is very different to the volar ligaments, where the ligaments stick very hard onto the base of the bones, both the scaphoid, which is here, and the lunate, and you don't have the same big recess as you do above the scapholunate joint, or the lunate, or the proximal pole of the scaphoid. I'll come to the dorsal recess later, because because inflammation or sticking down produces the impingement pain I think on dorsal extension of the wrist, and why, if you release this dorsal space, you can get rid of the pain often. The volar ligaments of the wrist are very important, not particularly for the proximal one, but mainly for the distal one, because it's this big ligament which runs between the scaphoid and the capitate. There's a ridge here just on this on the distal pole of the scaphoid, which goes over to the capitate, and it's pretty solid. It's covered up by other structures, like these are intercapsular ligaments, which further strengthen it. But when you actually look at this, you can see how strong it is. The importance of this is that the distal pole can only pronate if you have a fracture across the waist. And this is why that when you try to reduce scaphoid non-unions, it's hard to reduce it and twist it round. And sometimes you actually have to deliberately divide that, which I don't particularly like, because it may actually be a way in of the blood supply and things. But but this is a very important ligament in scaphoid non-union, and why it pronates from the distortion you get. Classifications are pretty poor in scaphoids. All these ones about distal pole, waist, and proximal poles are not based on anatomy, they're based on radiological views. And because the radiological view is distorted, all these classifications are distorted. We've also got things like Tim Herbert's one, which is a mixture of non-unions and things. And we got this is a French classification, but you've got multiple lines, and most of these are because people are mixing chronic non-unions, where the lines have shifted because of the collapse, rather than different fracture types. We spent some time looking at the fracture patterns in 3D from X-rays. You get marking plastic models and X-raying wires, and we're the best way to look at it. I'll tell you what we came up with, but I unfortunately think I'm a bit wrong. There are three main types. There is the one, which is a fracture which goes in the anatomical waist. It is right angles to the long axis. You can see it here in this 45-degree PA view. You can see it on that same view as we showed you before. On the standard X-ray views, you can't see it because it's an angle. These are the oblique fractures, which I thought all ran down the gutter of the of the sulcus, and this is why I call them sulcal fractures. And then they got kind of comminuted or more variable here around the waist where you get the crunching. And these are the three various types, I thought. What I didn't say, there is definitely a fracture which comes down here. Why that's important, I'll talk to you a bit later about that. And these are the oblique ones, which you can see more readily because it's 45 degrees. You can see this on a fairly standard views. And on this lateral view, it's sitting like that. Proximal pole fractures, I thought ran from inside below the dorsal apex ridge, because this is where the dorsal scapholunate ligament attaches, and it was all through the articular surface. In fact, I think there's a separate type which comes down more proximally than that. You can't see them because they're mainly acutely displaced. When I took these pictures, I thought it was because we had a large proximal pole is why you could see them. But I think this is actually a fourth type of fracture, and it's very rare to get displacement like this on these fractures. It was thought that the position on the scaphoid was the main cause of non-unions or the why the rate of non-union, but in fact it's probably more to do with stability and what happens to it afterwards, since I think there's two very distinct ways of how things go to non-unions. There's the stable one where you get sclerosis, fragmentation, or cyst formation, or you get the other ones where you get the waste ones where you get mechanical displacement. But that's for some other time. The transverse waist fracture is fairly stable on the long axis. As I said, there's a big ligament which tends to pull it into pronation, and you can see what often happens with these. They slightly rotate, and because the ligament remains intact, and then it heals. If it's very loose, it can suddenly grind. You get this sclerotic non-union. You can occasionally get a fibrotic one as well. And these are the pictures of the rotating transverse waist fractures on 3D CT. The sulcal fractures are much more what the type which you think of the humpback scaphoid. I think the actual humpback scaphoid is a bit wrong, and it is actually stopped us thinking about an important feature of these fractures. This is a 45-degree AP oblique. You can see it opening it up, and the angle. This is what I was trying to measure, and as I said, it's very difficult to measure the true angles. But here you can see it's very collapsed. But what's which is worth noting is this great spike out the back, which is one of the reasons why that if you get a malunion after you fix it, this causes problems. And this obviously, these types of fractures tend to cause the dizzy deformity more. So this is one of these unstable fractures. What they tend to do, it's in this line, they get compressed. A lot of them dig in like this, and you form a humpback scaphoid, but a lot of them use the scaphoid, particularly in younger patients and the athletic ones, where it actually keeps cutting in, and you end up something more like a speed rider's helmet with a big spike at the back. And that spike can actually, we've had a couple of actually rupture extensor tendons on that. But the interesting is the picture of the scaphoid down here is foreshortened and is like a T. So the fracture isn't distal, it looks distal because the distal half has folded over. It's a waist fracture, well collapsed. The proximal poles, as I say, are interesting because you could conceive these as fracture dislocations because they are below the ligamentous attachment to the lunate, and so you can get scaphoid fractures like that, which become more unstable if the ligament goes. But remember, they can only displace in that direction. This one can't displace at all. So the only movement you get with proximal pole isn't a humpback, but this end comes up, and that may you sometimes get a little fragment of the lunate as well, which is probably attached to the ligament. We also have described fragments of the scaphoid as well, which indicates the scapholunate dorsal ligament rupture. So this is the classic proximal pole. I don't know if you can see this around here, but there's a volar step. But what happens is that this remains in the same place, and the scaphoid just slides up, and this forms an osteophyte. And this is one which a bit more developed. These are very oblique fractures. There are some which are less angled than that. The anatomy is also important when you start to fix these. Do not fix a proximal pole from the far end, because you almost invariably do this. The other thing is that if you're going to graft a proximal pole, the most difficult thing is to all you can get at is articular surface. So putting a vascularized bone graft in this area is very difficult, because you end up with a surface which is graft, and you've damaged the articular surface. Interestingly, often with these, the articular surface is actually healed, which shows how stable it is. But this is, I tend to put I put the bone graft through a hole just underneath the flap of the dorsal recess, which I described before. But this is a proximal pole, and why it's difficult. You should, if you fire from this end, it comes out here, as you can see in this scope. So it's better to put it from the near end and go up antegrade. And sorry, this is how I show I do my bone grafting. I make a small hole in the articular surface, and don't put anything back in there apart from pack this with cancellous bone, but it's underneath the recess, and is the one part which is not particularly articular. These more recent CTs, 3D CT mapping, has shown what I thought was probably, instead of having 1, 2, 3 different fracture types, in fact there's a progression. And this is why classification is so difficult, because it doesn't, so you start with some fractures which are stable, and as it goes further and further, then they have a different natural history. And a lot of this also depends on where they come out of this, and how much the attachment has been. So that is this, I think, has been the hardest thing to try and I'm still working on that one. Sorry, I've got enough. Okay, not too bad. Transcarpal injuries. I'm going on for this because it's interesting. In transcaphoid perilunate injuries, the scaphoid fracture is different. It tends to be, you get the comminution dorsally. So in these, the scaphoid is going dorsally, and the top and the crunching bit is dorsally, not on the volar side. And when we first started, when I started doing a lot of transcarpal injuries, there was very little on it in the literature. Green had written a long article on it, which basically said that most of them were missed initially, and they invariably came stiff and all sorts of problems. And what I was trying to do, same as with the fracture dislocations of the elbow, is to try and get a way of fixing soft tissue and bone together so well we could get early mobilization, which is what we do in the elbow, but we weren't doing it in the wrist. So again, I went back and looked at the anatomy of this, because we had pictures like this of these little ligaments between the bones, and we had even pictures of people trying to put sutures into those. But it was this thing where about these bands of tissue dorsally on the back, which was attached then to the capsule, or more, or the actual ligaments on the volar side, which stuck down to the bases of the bone. And if you look at this is a cadaver specimen, but what it does show, this is the lunate, and you can see these fibers coming down hard onto the back of the lunate. And again, there's this dorsal recess, so it's at the distal rim of the dorsal of the lunate. This is the scaphoid, with which in most people there is some degree, but much more thinner than this type. And the triquetrum, it is stuck down very hard, so much so on the back of the triquetrum capsule that often you pull a bit of bone off with it. So this is not quite the representation, because the main ligaments are actually over the lunate here. This is the other picture of the anatomy of the carpus, which is worth looking at. This is dorsum, this is volar. These are the volar ligaments which are solid. They stick on the base of the capitate, they stick on the base of the lunate, and there's no give in them. The dorsal, there are recesses above the lunate and recesses above the capitate. And what's very interesting is, if you then think about how this extends, that this turns around, this slides down, and these recesses are important to keep the movement of the wrist, because this side is stiff, and in fact, as this extends, this buckles in. So the recess is very important. If these recesses stick down, you lose movement, and it's not movement you lose because of they block. It's the fact that these recesses don't glide. And you can see that again. This is the lunate. This is in fact volar this side, dorsal this side. Again, these recesses over the back and of the lunate and the capitate, and the very thick stuck on capsular ligaments on the front. And the scaphoid, the proximal pole, is much lighter, and there's nothing up on the distal end. These pictures which we see, they're all very pretty, but they don't often reflect what you find in them. That these stronger fibers are much more diverse than that. We also found lots of fibers going up towards the hamate and the capitate that way, and they sometimes come across all the way across to this side. They're highly variable. But what is important is this longitudinal structure over the top of the just distal to the midline of the proximal pole. Again, this is just to show the same thing with the very thin ligament here, but a very thick thickening in the capsule above. Also with ligaments, most upper limb injuries are shortening injuries. So you don't snap ligaments, you lift them off and you produce Bankart type lesions. So a dislocating joint pushes the periosteum off. It can also tear off like that, but it's normally after it's been pushed off, which is different to, say, the medial collateral ligament of the knee or an ulnar collateral ligament, which tend to be opening up of the thumb, MCP of the thumb, which are opening up ligaments. But most ligament injuries are more the push-off type. So if you look at the perilunate and lunate dislocations, it was thought the main field of progression is, to be honest, makes more. To me, it's a good aid memoir, but it actually I stultifies thinking about this because there's all sorts of problems with it. Firstly, there's no ligament which joins the lunate to the capitate, and you don't get a progression like this. It just can't happen with the soft tissue injuries you find, because and views of ligament injuries happening like this is also a bit bizarre, because a capitate doing this is not very likely. What you find with most of these injuries is the back of the lunate and the proximal pole of the scaphoid is torn off the capsule, and you get big Bankart lesions on the back of the radius. And as you can see, that what drives all this is basically the capitate pushing, and it goes with, and the scaphoid comes with it over the top. It then, with the perilunates, then pushes forwards and pushes the lunate back forward, and this is all based on the anatomy. So my proposal, and this would fit much more with the soft tissue injuries, is this is the capitate. It pushes over the top of the lunate. You get an increasing dizzy deformity. The capitate then tears off the capsule from the lunate from the capsule. It goes further off and produces this Bankart type lesion on the back of the radius, or you get a tear here. The Bankart is actually more common. Then it pushes this down, and this pushes through a transverse tear in the volar capsule. And if you look at, this is the form Frust before the lunate's been dislocated right down, that you tear off, this is the lunate tearing off and you'll get a footprint off the back underneath of the capsule, and you get varying degrees of either tearing off the proximal scaphoid or tearing off the back of the triquetrum, which often with a bit of bone. This is a reduced lunate dislocation. That's the back of the lunate. It's completely bare. That is the fingerprint where that has pulled off. That's the capitate. That's the hamate. The triquetrum is attached there, because so the capsule is attached to that. I can't see the scaphoid on that one. This is me with a transcaphal perilunate dislocation, but this my scissors is under these big Bankart lesion type liftoffs of the periosteum. In fact, this, I had one where we had desiccated scaphoid as well, and this hole went all the way around the styloid, all right around to the spacer Poirier tear. So these shortening liftoff injuries of the radius are very common with these and need to be sorted out. The anatomy of the volar surface we all know about because it's the classic exam question, but the spacer Poirier, we have this weak spot, which is supposed to be the shape of a V, but virtually all the tears I've ever seen on the volar side are completely transverse. And in fact, this often goes further and goes around the radial styloid. And in fact, in many ways, once you reduce it, you don't need to sew it because these fall together and will heal well at length. So once you pop your, we all do it, repair it, but I don't think they're actually needed. So if you're trying to do any operation on the these carpal fracture dislocations, you can use the Mayo approach, but you have to think about repairing this back because this part is still one of the most important strong stabilizers of these joints. If you do the modified, you take it all the way along the radius, and I just lift up the capsule like in this section, which is about to reduce. This is a lunate dislocation, which I'm just about to fix. We fix it with what we call the washing line technique, and this is all based on the anatomy. We put anchors in either both sides of the where the capsule is being pulled off, or just one side, and we pull it through. So this is the same one, pulling it up. These are the two anchors in the back, and this is a case with a perilunate, sorry, a lunate dislocation. This was reduced. You think this is all right, but you can see the very classic step in the showing how loose this lunar triquetral ligament is. In fact, if you did a CT scan of that, this will be even more displaced than that. And we fix it by putting the two anchors in like that in the washing line, and then that reduces the lunar triquetral ligament and just about reduces the dizzy deformity. Here's a few more. Here's one where you can see the lunate sitting down here. We got the two bones, and there's the imprint. I'm showing that's the sign underneath the capsule where the footprint where this is torn off. This is again the same one which I showed you before. This one you can see this is a proximal pole scaphoid. This is lunate still not reduced properly, and you can see the capsule is still attached to the proximal pole on this one. And on these are extremely hard to reduce because they often the lunate is rotated and it's hard to pull it through from the back, but you can do so. Transcaphoid perilunates. This is to show the comminution on the back of the scaphoid. Again, you can only really get to these with the true modified, the true Mayo approach. But again, thinking about repairing on the way back down. Here's us fixing the scaphoid at the back. And here's the lunotriquetral ligament, which I repair with anchors through there and fix the scaphoid. And this is, in this particular one, I fixed the fragment on the dorsum back. So we got the picture with the anchors all the way around, which is based on the anatomy of the capsule. And this sort of capsular injury also occurs in scapholunate and lunotriquetral ligament injuries in the same way. I was talking about the dorsal recesses. I think this is really important because if it's one of that sticking down is one of the major causes of dorsal wrist pain on impingement pain. And if you arthroscopically open that up, these are the patients when you scope, it's very difficult to go along the back of the lunate with your scope because this space is stuck down. If you use a blunt dissection, just open it up, it often removes the pain because the capsule isn't pulled in. The same as if you've got synovitis in this area, it gets compressed in that. Carlos, do I have enough time for just this will take me 10 minutes, the ligaments of the wrist. Are you happy?
Yes, please go ahead. Yes.
Okay, so ligaments of the thumb. One of the most interesting papers I read was a short one by J. Ollie Edmonds, which showed that, which basically told me that the beak ligament and was not the main cause of the problems in the CMC joint of the thumb, and it wasn't the real cause of the OA. There's basically three main ligaments in the thumb. The trouble is, if you read about the anatomy, it's highly variable. But the three main ligaments for the CMC joint are the volar beak ligament, which goes from the volar side of the trapezium, and it's the beak. It's more important to call a volar beak ligament rather than the beak ligament, because it doesn't go from the beak to trapezium. It goes from the whole front of the beak, and it's probably as much important as a rotate to stopping rotation. The intermetacarpal ligaments are I think undervalued, but the main one for stability and why you get laxity is the dorsoradial or the dorsal oblique ligament, which runs up from the back from the trapezium up towards this corner of the metacarpal. As we know, it's all a saddle joint, but as you oppose, it rotates the whole of the saddle, rotates the thumb in towards the fingers, and the beak is actually in a recess in the front of it, and it's almost like it rotates around there, because you certainly get wear in this area. But what happens is it's this dorsal oblique ligament which tightens up as the finger, the thumb goes into opposition, and that's what stretches. The beak ligament is only actually tight on abduction. This is the dorsal ligament. You can see how tough it is. This is it's oblique, and it goes towards the radial side of the base of the metacarpal up here. So this is a dorsal oblique here. This is where you often get pain with both instability and the instability of OA. And that is probably a mixture of tendonitis, of the APL. It may be the bursitis here. It certainly can be this edge rubbing and synovitis within it. When you scope this, you can often find the synovitis is up in this corner more. It's certainly where you can get the pain. You can also get pain from the volar ligament as it gets pulled. So these are the two places you tend to get pain here, and in the volar aspect of the thenar eminence, and also the dorso radial bit. When you dislocate the CMC joint of the thumb, again you get these Bankart type lesions because it's a shortening injury, and you lift the beak ligament off the metacarpal, and you lift or you tear off the ligament off the trapezium. In fact, one of the first patients I ever saw with this is we just repaired this down, and it became stable after an Eaton Littler procedure actually had failed. And so this is the beak ligament, and it gets lifted off. It goes down. You get this Bankart lesion on the back of the trapezium, or you get it to tear here. So these are actually quite easy to fix because you can go dorsally, obviously avoid the artery, and I put an anchor in basically at the level of the articular surface and tighten up. If I've got a loose joint, I use the alignment of the ligaments here, and I'll do a whip stitch up here and use the pulley effect of the anchor to pull this down, so it pulls the dorso-radial corner of the metacarpal inwards, which stabilizes it. The most interesting thing at the moment is the IML. I think the IML is a very important ligament in the thumb. Why it's important is because if you take the trapezium out, this is supposedly the only ligament which is stabilizing and stopping the metacarpal dropping down. I do actually think that the first dorsal interossei muscle in its fascia also may have it, and there is a dynamic extender or stopping it falling down, and that's the intrinsic muscles there. But the IML is probably the main problem, and this can be damaged either by the osteoarthritis. It can be damaged because it's slowly stretched, certainly when you get a subluxed thumb. But I also think it can be insufficient congenitally because because it's amazing how often, if you take a trapezium out one side, and it collapses, you'll exactly the same will happen on the other side, even if you haven't got bad OA. Of course, you can damage it at surgery, so it collapses. What we're studying at the moment is the pathanatomy here of the medial osteophyte, and trying to work out where it is associated with the intermetacarpal ligament, and see if we can predict how good it is after we've taken the trapezium out. And this is so that 80% of trapeziectomies do fine, but we're looking for the 20% who don't, who probably need a suspension. So comparing trapeziectomy against LRTIs is actually nonsense, because they actually, you do trapezectomies when you've got suspension still, and you do the LRTI if you haven't got suspension. It's relatively straightforward. Also, the anatomy is important about which tendon to use. If you use FCR, it is actually quite away from the IML, which you're trying to replace, and you tend to make it too tight. And this is why it's so difficult often for the patient to put their hands flat. The ECRL ligament, I find actually by chance, I was putting a tightrope in there, and I suddenly saw this insertion. I was trying to support this dorsal ligament, but I suddenly realized that we've got a broad ligament, a tendon here, which attaches very close. So I used a strip of this and reinforced the ligament. I also used it to go round and make a quoit round it, because I didn't want it to pull this too tight in, but this allows a much better extension. And it's the LRTI I tend to use when I'm doing, say, it with a wrist arthrodesis or a total wrist replacement, where you have to go dorsally anyway. Oh, sorry. Oh, sorry, we've come to an end. Thank you.